Here is heart failure. This is still a perfusion problem. In fact, this is the #1 exemplar for perfusion. This will be related to the other chapters under cardiac, specifically the conditions that lead to heart failure. So pretty much chapters 32, which is hypertension, 33, which is CAD and ACS, 35, which are dysrhythmias, and even 36, which are inflammatory and infectious diseases of the heart, all lead to heart failure. So let's begin. By definition, heart failure is not just a disease. This is actually a state. Okay, it is a complex clinical syndrome which results in the heart is unable to do its job, which is to meet the oxygenation needs of the entire body. And as mentioned here, these are the other chapters that I said that can lead to heart failure. In fact, when we go to the table shortly, you'll see that several diseases, both cardiac related and non-cardiac related, can lead to heart failure. We already discussed preload and afterload in chapter 31. So the severity of the heart failure or cardiac output in general depends on, again, the three elements of perfusion, namely the pump itself, which is we're referring to number 3, myocardial contractility, preload, which is blood volume, and then afterload, which is the blood vessels, and the heart rate also, because that determines your cardiac workload. Table 34-1, these are the primary causes of heart failure, or you can say these are the direct causes of heart failure. As I already mentioned, hypertension, chapter 32. We have CAD, chapter 33. Rheumatic heart disease, that's chapter 36, including congenital heart defects also, although we have congenital heart defects affect pediatrics, so it may not be mentioned in chapter 36. Pulmonary hypertension is obviously a chronic or even acute respiratory disorder, namely a pulmonary embolism. COPD also falls under pulmonary hypertension. Sleep apnea can also lead to pulmonary hypertension. Cardiomyopathy, that is chapter 36. Hyperthyroidism, that's an endocrine disorder. I'm sure you guys have discussed one of the complications of hyperthyroidism is cardiac disease. In fact, it's actually both. Hypothyroidism can also lead to dysrhythmias and therefore can lead to heart failure as well. Valvular disorders, particularly that caused by mitral stenosis, because of course the mitral valve is on the left side. So if that valve does not open completely, that will result in congestion in the left atrium. Not only will cardiac output therefore be decreased, but you'll also have pulmonary congestion, crackles, pulmonary edema, etc. Myocarditis is in chapter 36, and that is the inflammation of the muscle layer of the heart, the middle layer, the actual contracting layer of the heart. You have table 34-2, more causes of heart failure, but you can say these are indirect causes. I already mentioned, so sleep apnea, for instance, these are This will cause pulmonary hypertension along with the PE and the rest. There are generally two types of heart failure. We have left side and right side. To understand the resulting signs and symptoms of each type, I told you guys in chapter 31 during discussion of the assessment chapter that you needed to review the normal flow of blood from the moment deoxygenated blood returns to the heart and leaves the heart to go to the lungs, returns to the heart again before leaving it again through the aorta, because the symptoms will depend on blood flow. Okay, so I'll show you shortly. You can read these. I prefer to go to the signs and symptoms. That way we can explain the mechanism by which, how did the symptoms appear, and it's easier for me at least to describe how it develops. Okay. Let's review quickly. We discussed this already in chapter 31, that there are at least two main compensatory mechanisms involved in whenever there is heart failure, or whenever the cardiac output drops. So the triggers are usually either low blood volume, low oxygen, low blood pressure, or low cardiac output. This is automatic. There doesn't have to be a long pause or a long time before the compensatory mechanisms kick in. So the moment the kidneys sense low circulating blood volume, or if the adrenal glands sense, the baroreceptors in the kidneys sense that blood pressure is low, this will automatically trigger the release or the start of these two compensatory mechanisms. So we have the RAS system, which is your renin-angiotensin-aldosterone system. So this renin-angiotensin promotes vasoconstriction, therefore increasing peripheral vascular resistance by vasoconstriction. And then you have the aldosterone system. The other half of this compensation is now the release of aldosterone from your adrenal glands, and aldosterone will cause sodium reabsorption, potassium loss, and water reabsorption. And of course, your catecholamines, epinephrine, norepinephrine, will trigger increased heart rate and further vasoconstriction. Part of the response of the heart to low cardiac output is the increase in cardiac workload will cause it to dilate and hypertrophy. We'll look at the effects of these two conditions as it relates to the development of chronic heart failure as a result of repeated constant exposure or activation of the compensatory mechanisms caused by these disorders here that we talked about in table 34-1 and 34-2, meaning the longer these conditions pose an additional burden on the heart, making its workload higher, then that will cause, of course, because these are not easy to manage. Okay, so as if these conditions here continue, then that means the compensatory mechanisms will also be ongoing. So the longer, again, the compensatory mechanisms last, then it will lead to ventricular dilation and ventricular hypertrophy. I don't want to discuss this again. This is part of your A&P, and again we have been discussing these repeatedly in chapter 31 and again just recently. Okay. I'll show you the this is what I mentioned. So if there is continuous activation of the neurohormonal responses, these two caused again by those conditions listed in table 34-1 and 34-2, it will cause an increase in the patient's heart workload, and therefore there will be dilation of the ventricles as well as hypertrophy. Although the picture's right here. So look at here, this is dilation, and so this is dilation. Dilation will result in the thinning of the walls of the heart, whereas hypertrophy causes the thickening of the ventricles. Now this although the dilation means there will be increased preload, therefore will stretch the heart, and we learned in chapter 31 that according to Starling's law that the more you stretch the heart, the greater the resulting contraction, correct? And however, we did say also that this will only be true if this happens in a short period of time, like not continuously. Remember when we talked about the underwear? Okay, so if a brand new underwear is exposed to stretching, it may be fine, because we're only stretching them for short periods of time. But if the stretching goes on for a long time, then of course Starling's law will not apply anymore, because just like the 2-year-old underwear or an overused rubber band, for instance, it will lose its strength eventually because it is now overstretched. Hypertrophy, although this looks really thick and muscular, hypertrophy doesn't always relate to the strength of the contraction. So as the muscles hypertrophy, they don't necessarily become stronger. In fact, they grow weaker. And there was something. Okay, all right. Counter-regulatory mechanisms. So if we have compensatory mechanisms, we also have counter-regulatory mechanisms, meaning just like what you learned in diabetes. So when we are in a starvation state, for instance, we don't necessarily die because we are pretty much made of food. We have proteins in our body, we have carbohydrate stores in the liver as well as in our fat deposits. So we have counter-regulatory mechanisms everywhere. For in the case of blood sugar, we can simply break down our sugar stores in order to increase blood sugar. In the same way, so we learned in chapter 31 again that when this happens here, when the patient is in congestion wherein the pump fails, and then therefore there will be pooling of blood inside the heart, that will trigger the release of a hormone from the ventricles. And we learned about BNP, which is B-type natriuretic peptides, the purpose of which again were two. We said that this will be the opposite of aldosterone, so therefore instead of it'll have the opposite of RAS, meaning instead of vasoconstriction, this will cause vasodilation, and instead of reabsorbing sodium and water like aldosterone does, this will do the opposite. So instead, this will cause diuresis. So two effects of BNP. So we have diuresis, which is mentioned here. So we have diuresis and vasodilation. So both of these will do the opposite of our compensatory mechanisms, which cause vasoconstriction and water reabsorption. This one is the opposite. So we have vasodilation and diuresis instead. So they counter the adverse effects of your two major compensatory mechanisms in heart failure. I mentioned this in your blueprint yesterday. So here we have heart failure classification. It's not that big of a difference from based on American Heart Association versus New York Heart Association. There are 4 classifications. So we have 1, 2, 3, 4. 1, you can disregard 1 because look at this. There is no limitation in physical activity. Ordinary physical activity does not cause any symptoms. So do we need to memorize that? Not really. So think of a patient with heart disease, but then they're okay, so they can function every day. So you will only need to remember heart class 2, 3, and 4. So 2, there is now slight limitation of physical activity. However, they are comfortable at rest. However, when they do physical activity, they have symptoms, but that's fine. They can either take nitroglycerin or take a rest, and then they will be symptom-free again. But the key word here is slight. So that's class 2. When we reach class 3, there is now moderate or marked limitation of physical activity. They are still comfortable at rest, but this time less than ordinary physical activity causes symptoms already. Meaning, ordinary activities would be going to the bathroom, taking a shower. So in class 2, they may have some symptoms. So they'll have some shortness of breath. In class 3, these are now less than ordinary, meaning you just get up probably to fetch something, walk somewhere to the mailbox. They probably can't do that anymore, because they'll be very short of breath. And then finally, class 4, these patients look unable to carry on any physical activity. So these patients probably can't get out of bed anymore. So these people will be bedbound and pre-departure. So these patients will be requiring heart transplant in order if they expect to live any longer. Now, how is this tested on the exam? Now, prepare on the NCLEX that this will be, again, the NCLEX is an integrated test. So this may not be even on a med-surg patient. An example shared by a student who graduated was, the question was on heart failure classification, but the patient was a pregnant woman. So the question went, the patient is at 35 weeks of gestation, so close to full term already, and she had heart failure classification a class 2. Okay, and the question went, what will be discussed during this prenatal visit. So we discussed the options available. So we ended up with, well, the correct answer there, because one of the choices was to schedule a C-section. So that was the only plausible answer, because in class 2, look at this, ordinary activity already results in symptoms of heart failure. Now, I don't know about you, I've never given birth, I've never been in labor, but I don't think a labor is very easy. Meaning, for this patient with class 2 heart failure who is at 35 weeks pregnant, she won't be able to carry out labor at all. Okay, so the best answer there would have been to schedule a C-section in probably 2 weeks. Okay, so that's an example of a possible question on this one. Okay, now let's go to signs and symptoms. Now, I mentioned that heart failure is a chronic condition. There is treatment, but no cure. Well, there is a cure. You'll have to have a heart transplant. That's the only cure. So similar to COPD, which are chronic bronchitis and emphysema, there will be problems day to day, but the patient's body learns to compensate, so they can live with heart failure just as they can live with COPD. However, there will be episodes we call acute exacerbations. So if there is an acute exacerbation in COPD, the symptoms of which are, let's say, they'll have crackles, they'll have increased respiratory rate, they'll be having increased dyspnea. It'll be the same pattern in exacerbation of heart failure. So by definition, acute decompensated heart failure is the sudden onset of the signs and symptoms of heart failure. We will discuss the symptoms shortly, but think of acute decompensated heart failure as a condition wherein these symptoms occur suddenly, all at the same time. Okay, so let's most frequent causes of these is either the patient does not comply with a medication, for instance, or with their diet. This is common during the holidays or when they have celebrations, birthdays, but mostly holidays. Another reason is, just like in COPD, if these patients get sick, so let's say if a COPD gets the flu or the pneumonia, or the same thing, a heart failure patient develops pneumonia or catches the flu, for instance. So this will impose an extraordinary strain on the already damaged heart. So therefore, it can exacerbate the condition and trigger, therefore, a acute decompensated state, or what we call simply as heart failure exacerbation. Most of the reasons we've seen, though, in clinical are people who have not been taking their medications lately. They're not all by choice. Some people just don't have the means to afford their medications, unfortunately. I will not test this table. This one talks about wet and wet warm. It's not really necessary. Let's go now to chronic heart failure. So when we discuss signs and symptoms of chronic heart failure, in acute decompensated heart failure, you'll see these all appear at the same time, causing considerable distress on the patient. So let's trace again the normal flow of blood through the heart. So we know that venous return of deoxygenated blood comes to the right side via the inferior and the superior vena cava. In the case of the blood flow through via the inferior vena cava, take note that it has to go through portal circulation. So that means it has to go through the blood vessels in the liver before it reaches the inferior vena cava. So in heart failure, since this is the pump, and if the pump fails, so therefore the pump won't be able to empty. So it cannot empty either or both from the right side to the lungs, and then or from the left side to the aorta. So as a result, blood will pool inside the heart, causing congestion. So if you look at the signs and symptoms on table 34-5, right side symptoms are on signs and symptoms are on the first column, second column, left-sided heart failure. They all demonstrate congestion. The difference is, look at where the congestion occurs in the left side, since based on anatomy, the function and physiology, the function of the left side is to receive blood from the lungs and pump it out through the aorta, whereas the function of the right side is to receive blood from the upper and lower parts of the body and then pump it to the lungs to be oxygenated. Okay, so think of it that way. So if we talk about a major intersection, for instance, of a series of roads, if there is now traffic inside the heart, so just imagine where this blood came from. So traffic, just like in traffic, if there's no movement in an intersection, there of course will be a subsequent traffic, backup of traffic from wherever those streets came from. Okay, so let's begin with the right side. So since the right side receives blood from the systemic circulation, both from the upper and lower parts of the body, so we said congestion will occur. So look at the resulting signs and symptoms. So there will be severe rise in pressure on the right side, both on the right atrium and the right ventricle. Heaves is described as a thrill, so it's like a vibration. So if you feel this patient's chest, you will feel the thrill or the vibration on the with each heartbeat. Okay, that's what heaves means. So we'll have murmurs because now because of the congestion, the valve, particularly the tricuspid and the pulmonic valve, may now no longer close completely because of the congestion. So as a result, some blood will now leak back into the previous chamber, in this instance to the right atrium, every time the right ventricle contracts, and that will produce, instead of a lub-dub, you will hear a murmur instead. Why is there jugular vein distension? So this is blood that is now unable to drain from the shoulders, the arms, and the head. There is edema in the dependent areas, the pedal, the ankles, the scrotum, the sacrum are all dependent areas. Now, I don't mean you and me, but in a patient with right side heart failure, these patients are not standing and walking anymore. So they are probably in bed, or in a chair, more so in a chair, because they won't be able to breathe properly, so they probably won't be able to lie supine. So because they have orthopnea. So there will be edema formation, because now imagine traffic and the veins can only hold so much blood. So if you increase hydrostatic pressure in a vessel, water will leak out. The cells won't leak out, meaning blood won't come out, because they're too big. Those molecules are too big. Water molecules, though, are small enough to be pushed out. There is weight gain. The weight gain here is owed to the oliguria that results, because cardiac output eventually will drop. Okay, and plus the edema here, that means these fluids are no longer inside the cell, nor are they inside the blood vessels, but now they're in between. They're in the interstitial space now. But just remember that the edema formation here is caused by increased hydrostatic pressure, meaning just the sheer volume of fluid in the vessels will cause the fluid to leak out. course, this will eventually drop cardiac output, so it will trigger increased heart rate, and edema won't stop there. So remember, where does all this blood came from? They have to pass through the liver, and that means the esophagus, GI organs cannot drain as well. So if there is leaking of fluid in the ankles, in the when I say leaking of fluid, leaking from the vessels, okay, they're not coming out of the skin, they're still inside the body but inside the interstitial spaces. So therefore there will be ascites. So if you have congestion now in the GI circulation because of congestion in the portal circulation, so that water will leak and then find any dependent area, which happens to be the peritoneum, and eventually the patient will have a whole body edema here, because right now we're just talking about the lower part. So imagine the upper part of the body as well. So the shoulders will have, and the upper arms will also eventually have edema. And if this happens everywhere, so of course the liver will also enlarge because of the congestion in the liver as well. And that will explain also the patient's complaints now. So they'll have fatigue because of course your cardiac output is low. Now the weight gain here, what will make the weight gain worse is because there is now less forward blood flow. Not enough blood will go to the lungs and then back to the heart. So of course cardiac output will suffer here eventually, and now there will be less blood flow to the kidneys. Kidneys' job is of course to regulate fluid and electrolyte balance and blood pressure. So if they don't receive enough blood flow, so they will stop making urine as well. So we typically make about 1500 mLs of urine per day. Since we're not doing that, so let's say we're only making 400, so the other 1100 that's supposed to come out is now inside the patient's body. Okay, so that accounts for the weight gain. Let's go now to the left side. So if you have heaves on the right ventricle, you'll also feel heaves on the left. Okay, so let's review the job of the left side again, is to receive blood from the lungs, from the left and right lungs, and then pump it out of the through the aorta for systemic perfusion. Now it cannot do that because there is congestion there too, so the left side this time failed. So this will again lower cardiac output, because this is the left side we're talking about. So the left side's job is to determine, the left ventricle really determines cardiac output here, because it is the last chamber that will pump blood through the aorta. So cardiac output drops, that will trigger sympathetic nervous system, so you have increased heart rate. This is chronic we're talking about. Okay, so in over time, of course, there is now hypertrophy at this point, and so the longer the congestion goes, again, this blood is coming from the lungs. So if you have less ability of the left ventricle to empty, therefore there will be traffic in the left atrium, there will be traffic in both lungs. And if there is hydrostatic pressure in the periphery causing edema in the periphery, this time you'll have edema as well in the lungs, manifested by crackles in both bases. You'll have extra heart sounds as a result because of the increased congestion, and at this point some arrhythmias will probably also develop now, particularly AFib. There will also be pleural effusion, so the pulmonary edema, the water won't just stay in the lung but also leak out into the pleura eventually. So once you have pleural effusion, depending on the size, then that could potentially increase in volume and could collapse your lung partially. Changes in mental status, because now cardiac output drops, there will be less oxygen, blood and oxygen going to the head, so a patient will have changes including restlessness and confusion, indicating cerebral hypoxia. And because cardiac output drops, so you'll have symptoms of low cardiac output, weakness, fatigue again, depression, dyspnea, and the rest. The frothy pink sputum here again only appears if the pulmonary edema is really worse. Nocturia occurs, that is increased urination at night. There will be an explanation here. I'll let you read it. Let me explain it now. So nocturia, because at night when you're laying down plus the metabolic needs drop, the heart suddenly is now, because there's less oxygen needs at night, because you're getting ready to, you're already sleeping. Therefore, the fluids mobilize and go back to the vascular compartment. This will suddenly increase blood volume, increase blood flow to the kidneys, increasing GFR, increasing urine output. Please review the explanation for each of the symptoms, which are explained in detail in the preceding paragraphs. Paroxysmal nocturnal dyspnea is almost exclusively seen in patients with heart failure. This happens at night, obviously. So the patient here is awakened. Okay, so this happens at night, and then they have this feeling of suffocation because there is reabsorption of fluid back into the body. So in essence, this will increase blood volume and therefore will result in symptoms of fluid overload, and this awakens the patient, and this happens 2-3 times a night, because they have to plus you have nocturia on top of this, so all of these also will contribute to the fatigue. So the patient doesn't feel rested because they had to get up 2-3 times or more during the night. I already mentioned these, so please read them. Complications, I mentioned pleural effusion and dysrhythmias, particularly AFib. In chronic heart failure, especially during acute decompensated heart failure or during an exacerbation, on top of an AFib, patient may have more lethal dysrhythmias, ventricular dysrhythmias, particularly VFib and VTAC, okay, which may cause, because these are lethal, these are fatal dysrhythmias, okay. They result in VTAC, for instance, results in a really high heart rate. We're talking about 200-300 beats per minute, and that consumes a lot of oxygen, plus it doesn't really produce any cardiac output. It's just because the heart is just beating too fast, so there's no time for the ventricles to fill at all. And VFib, on the other hand, I mean, the heart's kind of beating, but not hard enough to produce any cardiac output. So think of so this is the ventricles fibrillating as opposed to the atria fibrillating. So it's just quivering, okay. Both will have zero cardiac output, so therefore this will cause cardiac arrest. The last few complications are left ventricular thrombus. This meaning it's just simple as there's a blood clot forming in the left ventricle, as opposed to blood clots forming in the atria, resulting from atrial fibrillation. So whenever you have whether VFib or atrial fibrillation, blood is not moving, and particularly in AFib, when you have a clot there, then you have a very high chance of a stroke, an embolic stroke. Hepatomegaly, I already mentioned, and heart failure or renal failure. This is in chapter 46. You will learn that this is what we call pre-renal kidney injury that will result. Diagnostic studies is quick. We discussed this in chapter 31, and we said that the very specific marker for diagnosing heart failure is BNP. Again, this is the hormone. This is the counter-regulatory hormone released by the overstretched ventricles. This is not present in any other condition, so this would most likely indicate heart failure. That's not the only one though. We also do, because like I mentioned previously, patients with heart failure having a dysrhythmia, COPD, a PE, all present the same way. So they come into the ER grasping their chest, they have chest pain, they have severe shortness of breath. So we try to cover all bases. We can't just draw one blood at a time. So BNP, of course, will have to be drawn along with cardiac enzymes, troponin, TNI, CKMB, thyroid, because it could be a thyroid storm, and lipid profile, kidney function tests, etc. We'll discuss treatment in detail shortly. Okay, acute decompensated heart failure. These are very sick patients. They are most likely in, if not in telemetry units, they will be in ICU for a while. They are critically ill, and during treatment we cannot afford to wait for symptoms to manifest before we do treatment. So the best way here is to anticipate the impending decompensation. In order to accomplish that, we have to be able to measure pressures inside the heart rather than outside. So we will need a pulmonary artery catheter. I'll give you a crash course on it. So a pulmonary artery catheter is a catheter. It's a long catheter. It's about, it can be up to 100 centimeters long. And so what it does is we insert the catheter. The doctor inserts the catheter either in the ICU or in the radiology. This is inserted blindly. It's a pliable, spineless catheter. It doesn't have a guide wire, so it's like a limp noodle. There are dangers, of course, in inserting this, because the catheter could coil either inside the right atrium or the right ventricle, making, it could create dysrhythmias during insertion. The catheter is called the Swan catheter, but it's really a pulmonary artery catheter. So let's watch a demonstration.
This is a demonstration of Flip4Mac.
Alright, so by the way, the catheter has about 5 lumens, 5 pigtails. So it's one catheter. The tip has a balloon, so there will be 2 holes here. I mentioned there are 5 lumens, right? So they're color coded. The yellow one is attached to the tip of this catheter, which will be attached to a transducer, which is a pressure monitoring device. This will measure, because the the tip of the catheter lies in the left atrium. So when the yellow catheter is attached to a transducer, therefore it will measure pressure in the pulmonary artery. There's another hole, an opening, that is colored blue. Okay, that one will be called the CVP port, or the central venous port, or the right atrial port. So the tip will measure pressure on the pulmonary artery, which is obviously on the left side of the heart. And then you have the other port opening in the right side of the heart. So what they'll do is inflate the balloon. This thing is like a Foley, so they inflate the balloon. So here you inflate the balloon. Of course the doctor can't see this, okay, so he made an incision in the neck and then threaded this from the internal jugular and then down. So he keeps pushing this thing. This is obviously sterile procedure. Okay, so we can't see how this is. The only way he'll know is through the transducer. So the pressure will be monitored. Each chamber has a different waveform because the pressures are different from atria and ventricles. So if the waveforms are like this, the pressure waveforms, then he knows he's still in the atrium. So remember, this is a wet, like a wet noodle. Okay, so this could coil. So if the pressure doesn't change, that means you're just in the atria. And then the longer because there are markers, 10, 20, 30, 40 centimeters, so you would expect it to advance already. So if the waveform doesn't change, then that means the catheter is coiling up inside the chamber. So what he'll do is just deflate the balloon, try again. Hopefully it advances, so the waveforms change like this. So it won't advance unless you inflate the balloon. So the balloon here is like a sail. So the pressure of the blood flow will just carry the catheter. So you keep going. So he's entered obviously the right ventricle, and then the pressure changes again when he reaches the pulmonary artery. Okay, and then when he occludes that part, that tells him he's gone too far and has now occluded the pulmonary artery. So if you look, what did I do here? If you look there, he has to deflate the balloon because the pressure is now wedged here because he occluded it. So he'll deflate the balloon and then the pressure resumes, and we leave it right there. Okay, so let's watch now how this thing measures the pressure. So again, the yellow port is attached to a transducer, and the blue port, which is attached to the hole here, they will be both attached to a pressure monitor, a transducer. So they will measure so if you look at it, the CVP obviously is on the right side, so that one is clear to see. It's measuring pressure on the right side of the heart. This one on the pulmonary artery, although this one is not in the left atrium nor in the left ventricle because it's impossible to put it there, as long as this is in the pulmonary artery, this is measuring indirect pressure of the left side, because whatever's happening on the left side anyway, on the left atrium or the left ventricle, will be reflected on the pulmonary artery, because the blood coming into the left atrium and the left ventricle is coming from the lungs. So therefore, if there is congestion of blood in both lungs, it will be reflected on the pulmonary artery. So therefore, this is an indirect measure of the left side of the heart. So why do we need a Swan? Well, it's like I mentioned, it's easier and the patient will have a better outcome if you anticipate or see the pressures change in real time rather than waiting for crackles to appear, rather than waiting for the patient to be short of breath. So as the pressures increase inside, the physician and the nurse can already perform interventions, administer drugs in order to prevent it from um, getting worse. Okay, and this is the normal range. So the PAWP is between PAWP is pulmonary artery wedge pressure. So, or simply put, it's pressure on the left side of the heart. So it's between 8 and 12. Other textbooks say 4 to 12. Don't worry about the difference. NCLEX will use really low numbers or really high numbers. Look at this. If a patient has COPD exacerbation, the pressure can reach as high as 30. And the CVP, of course, I think CVP I didn't see on this chapter, but it's usually between either 1 to 6 millimeters of mercury or 1 to 8 millimeters of mercury. So obviously the pressures are lower on the right side compared to the left, because the left ventricle is more muscular. The other devices here, like the aquapheresis, intra-aortic balloon pump, or ventricular assist devices, are advanced interventions. We will not test them. Okay, so they're just nice to know at this point. However, every patient, almost every critical care patient, will have a Swan, so you need to know this concept. There are alternatives to a pulmonary artery catheter, but they're not as reliable as a pulmonary artery catheter. Okay, it's still very useful nowadays. There are alternatives like echo. They can also estimate the hemodynamic pressures inside the heart using a Doppler, but they're not as reliable as the information given by the Swan. Drug therapy now. I mentioned an acronym in chapter 31. It was doable. That's not my original acronym, by the way. I just borrowed that from somewhere. I heard that on an NCLEX review. Okay, so the doable here stands for digoxin, which is for chronic heart failure. Then we have diuretics. Obviously, this is for both acute and chronic heart failure. Oxygen. We have ACE inhibitors or angiotensin receptor blockers. We have beta blockers. And then we also have BNP. BNP is nisiretide. This is a made from human BNP. Then we have L is low sodium diet. E is exercise, and this is smoking cessation. Alright, I won't repeat these drug therapy because we did discuss them, most of them anyway, in hypertension, chapter 32. So the good thing about cardiac is they have similar medications. So I will only discuss the ones that are new. So diuretics. Remember, we have three: loop, thiazide, and potassium diuretics. ACE inhibitors, and ARBs. I'll point out a few differences, okay, because these will be discussed in the paragraphs that follow. We have vasodilators here. We have, obviously, these are long-acting vasodilators because this is nitrobid. And we also have some POs, isosorbide, those are POs. This is IV nitroprusside. The legends, by the way, here, asterisk versus the cross. Asterisk is chronic here, as chronic, and then the cross is for acute episodes, okay, acutely compensated heart failure or during an exacerbation. We have beta blockers. Take note, butamine and dopamine are only given during exacerbations. Okay, milrinone, it falls under the same category as Viagra and Cialis. They're all called phosphodiesterase inhibitors. Basically, they're vasodilators. Digoxin is for chronic heart failure. Then we have good old morphine. You can skip this drug. This is not really very commonly used. Sounds very expensive. And during if a patient is admitted for, let's say, complications like AFib, for instance, then they will be put on heparin. And plus, this is also prophylaxis for DVT, because these patients will have decreased mobility because they can't breathe. They have severe activity intolerance. Antidysrhythmic drugs we'll discuss under 35, okay, because we do have AFib, VFib, or VTAC. Please read these on your own. These are drugs, so the testable part again are side effects, expected versus reportable side effects, and of course your nursing responsibilities. They're mostly based on the side effects that may occur. Drug alerts, as I already mentioned, these are very testable. Please do not ignore them. Questions can be constructed easily from these, and it's very easy to support because it's right here on the textbook. Nesiritide, this is the recombinant form of BNP, as I already mentioned. We have morphine, positive inotropes. These are drugs that increase contractility. The warning here, especially for dopamine, is besides extravasation, these drugs, although they lower heart rate while increasing the contractility of the heart, by doing so, though, remember that the stronger the heart contracts, then the higher the oxygen demand and the higher the oxygen consumption. So this may cause chest pain as a side effect. And you already know we can't use Viagra with nitrates, so these two may not be used together. I'll discuss the Digoxin toxicity toward the end. They're not mentioned here. Alright, other interventions is of course oxygen, not mentioned here, but yeah, we give, obviously the patient presents with dyspnea, so they will receive oxygen. I already mentioned we're not doing CRT. CRT stands for cardiac resynchronization therapy, intra-aortic balloon pump, and even ventricular assist devices. Okay, these are advanced equipment. You won't see them commonly on as a new nurse. Here I'll leave you responsible for the diuretics. Again, there are three. We have loop, thiazide, and potassium sparing diuretics. ACE inhibitors and ARBs both cause, because of the nature of their action, they stop the RAS from occurring. So therefore, there will be no aldosterone, no sodium reabsorption. But however, because you're not reabsorbing sodium, that means sodium is lost, but you will reabsorb potassium. So that already tells you there will be hyperkalemia. Now, as far as hypotension, of course, this is a given, especially if you're giving any of these drugs for the first time. So your warning for the patient will always be about orthostatic hypotension, which precipitates falls. We have combination drugs now, and Entresto is very commonly used. It has come out in the last 2 years. This is a combination of an ARB and an ACEI. And here is the potassium sparing diuretic. You have drug alerts here, obviously that causes hyperkalemia. Now if I'll talk about digoxin toxicity under digoxin. Okay, so here are your nitrates. Again, these are prescribed if patients cannot tolerate the ACE or ARBs, ACEIs and ARBs. I mentioned this in the acute coronary syndrome chapter. If we're using long-term or long-acting nitrates specifically, the patient develops tolerance to them. So that's why, especially if you have the ointment will be on only during the day, and it has to be taken at night for about 10 to at least 10 hours, that the patient doesn't get any nitrates, so they don't develop tolerance. Alright, let's talk about digoxin toxicity. Digoxin is not a very safe drug. In fact, if you've already read chapter 35, Dysrhythmias, this is a very common cause of dysrhythmias, particularly heart blocks. The levels are have to be maintained in a therapeutic range. The two most common conditions that will cause toxicity is hypokalemia and kidney injury. Reason is the digoxin enters the cell via the sodium-potassium pump. Therefore, it needs potassium in order to enter the cell. So the lower your potassium, the more digoxin is left floating around in the bloodstream. And by contrast, if your potassium is also too high, it will result in inhibition of the action of digoxin. So either way, there's really no good thing about potassium levels being too high or too low. They will affect digoxin either way. Signs of digoxin toxicity, which is common, by the way, since most of our patients are both on digoxin and loop diuretics or thiazide diuretics at the same time, so they are constantly at risk for toxicity. So they need to know the signs. Here are your common signs. They'll have blurred vision, they have see halos around lights, anorexia, nausea, vomiting, headache, fatigue. The first symptom, of course, is bradycardia. We will not test this drug, as I already mentioned. This is not common. Oh, by the way, the Digibind, which is the antidote, or Digifab, is only given if you have digoxin level of, let's say, 2.5 or more. Okay, so if it's really high, the treatment for digoxin toxicity, as long as it's not severe, is typically just potassium. So the patient will be given supplemental potassium. As soon as potassium is normal, levels are normalized, digoxin levels will also become therapeutic. So we're done with the pharmacologic therapy. Let's do nutritional now. This is nothing new. We discussed DASH diet. So we still follow the DASH diet. In addition, though, we're very strict with the sodium intake. Typical order is 2 grams. You have a table here describing what 2 grams look like. Now, I won't be a hypocrite. I won't test you on the amounts, but rather in general, look at these statements right here. So this will guide your judgment when you get questions on how you choose or teach a patient on what food choices to select. So basically, do not use salt, okay? Because some foods are naturally salty, especially milk and dairy products already have a considerable amount of salt in them. So anything processed or canned and frozen meals, except frozen vegetables. So fresh frozen vegetables, that's fine because they didn't add anything to those. But whenever you have pre-prepared meals and are frozen, or whether it's pizza or pasta, they always have sodium content. Milk products, milk and dairy already have sodium. You can see it right here. Look at the cheese here. Look at the here, milk 126, and you have here wheat bread. Well, this one is 2, that's why it reached 300. Here, cheese, look at that, just one slice is already 300 grams. 300 milligrams, sorry. Alright, and teach them to read labels if they buy anything canned or frozen. They're also advised not to go out to eat so much. Home cooked meals you can control the sodium content better. As far as fluid restrictions, the patients are already on a considerable amount of diuretics, so there's really no need to restrict them. However, if they have a comorbidity of renal insufficiency, meaning they have some degree of kidney damage also, then we have to limit them to 2 liters a day. Weight is among the reportable symptoms. We have a extensive list toward the end of the lesson on when to call the healthcare provider. One of them is weight gain. So teach them to report if they gain 3 pounds over 2 days or 3 to 5 in a week. Here is our discharge teaching, which is important in maintaining as few hospital readmissions as possible. So this is taught to both the patient and the caregiver. So you teach them about diet, obviously. Please read these on your own. Activity, or that is exercise, that's part of our doables. If they smoke, then stop smoking. Alright, so here are the reportable symptoms, because we can say, report signs of an exacerbation. Well, they need to know what are those signs of acute decompensated heart failure or early signs that they may have one. So here's the list. So there's the weight gain there, the symptoms, especially if the difficulty breathing is increasing, if they have increasing swelling, more swelling than usual. Signs of toxicity, here you have nausea. Alright. Always balance activity with rest. In addition to dyspnea, of course, we have activity intolerance here. Drug therapy, very important that they understand why they're taking a certain drug, what to do, especially the counting the pulse rate part, because they're taking digoxin and beta blockers, so they need to know to count their heart rate. Here's the rule. So in the absence of a parameter given by the doctor. The default is below 60. Don't worry if the heart rate is exactly 60. They can still take it at 60 as long as they don't take it if it's less than 60. Because the doctor knows that, and we in heart failure, the lower the heart rate, the better it is actually, because remember, the higher the heart rate, the higher the workload. Okay, and then the heart here is injured, remember, because of the conditions listed in tables 34-1 and 34-2. So it's okay for the heart rate to be in the 50s. All right, it's actually ideal. And I believe that's it. We will not test end of life care. That will be another topic, as well as heart transplantation. This will be under immune disorders, as well as management of transplant rejection, which will be in another semester.